and hopefully the rest of the folks will join us shortly, but I'm sure we'll be getting updates as we go along. So at this time, I'd like to call the Joint Conference Committee meeting for Laguna Honda Hospital for May 10th to order. And let's see, Mark, can you call the roll?
Yes, Commissioner Chow,
Present.
Commissioner Green,
Present.
and Commissioner Guillermo.
Present.
And may I read the land acknowledgement, Commissioner Guillermo?
Yes, thank you, Mark.
The San Francisco Health Commission acknowledges that we are on the unceded and ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. Commissioners, would you like to go to the Regulatory Affairs Report?
Looks like, oh, I saw Roland
Michael.
and Michael.
Michael's here.
Oh,
Yes.
oh, we are here. Okay, great.
Yeah. So now I don't see Mike. Oh, there he is. Okay. So Secretary Morwitz, if you wouldn't mind calling out the agenda items for us.
And I skipped, let's go to item 2, the approval of the minutes for the meeting of March 8th, 2022.
Okay, if I could have a motion to approve the minutes.
So moved.
Second.
And there's no public comment. There's no one on the line, so I can go right to a vote. Commissioner Guillermo?
Yes.
Commissioner Green?
Yes.
And Commissioner Chow?
Yes.
The minutes are passed. Thank you so much. Item 3 is general public comment. And again, we have nobody on the line, so we can move on to item 4, which is the executive team's report. Zoe, are you going to show the, can you share your screen, or I'm not sure who's going to be showing it. Yeah, there we go.
Good afternoon, Mark. Good afternoon, commissioners. Our apologies for joining a little bit late. We were just wrapping up another meeting with visitors. Zoe, if you would please advance to slide 4. Thank you very much. Okay. So DPH is in the process of implementing an aggressive plan to recertify Laguna Honda and successfully pass our annual licensing survey. This includes activating the Incident Command Center structure to oversee the process and directing staff deployments for support. It also includes contracting with external experts to guide the hospital through the recertification process, on-site collaboration with CMS and CDPH partners, and of course, a tremendous amount of support on the ground for survey preparation at all levels of the organization. Our overall goal is to ensure ongoing patient safety while maintaining compliance and with all applicable regulations. Next slide. There are several important initiatives occurring simultaneously as we continue our preparations for certification. One of the most important is securing subject matter experts to guide us through the recertification process. Due to the situational urgency with which we're faced, we implemented an expedited contracting process for bringing these consultants on board. For a process that can typically take months to implement, we fast-tracked the request for proposals and conducted interviews over a period of a couple of weeks. We identified a finalist, and we have those consultants on board as of today. Next slide. One of our keys to success in recertification is ensuring ongoing continuous leadership presence on the units. So we've implemented a multi-layered management and leadership rounding initiative. Our quality team developed a comprehensive rounding tool to ensure a consistent approach across the organization. And our extended executive team has been deployed to verify and validate the corrective actions are implemented. This is part of our Trust but Verify campaign that will be critical to our ongoing success. Next slide. The next 3 slides provide some detail about what's being monitored during the rounding process. The focus areas are aligned with the actual findings from the recent survey. The first focus area centers on infection prevention and control. These are obviously basic expectations on every unit, but due to the deficiencies that were identified during the survey, it was important for us to verify on a regular basis that these actions were actually occurring. Next slide. The second area of focus is medication administration. During the survey, there were findings such as medications being ordered but not administered, and other instances of medications not scheduled to optimize their therapeutic effect. So it's important to also include this aspect in our rounding as well. Next slide. The third focus area is on the environment of care. Due to the extended length of stay that's associated with long-term care patients, many of our patients have accumulated excess personal belongings during their time here at Laguna Honda. So it's important for us to inspect patient rooms on a regular basis to ensure that the environment is free of hazards. We also use this opportunity to ensure that patients' environments are comfortable, including their room temperature, their water temperature, and things of that nature. Next slide. So at this time, I'd like to take this opportunity to welcome Terry D'Antoni as our acting chief nursing officer. Terry's been on board here with us for a couple of weeks. While she's serving as our acting chief nursing officer, Terry will continue in her role as CNO over at Zuckerberg San Francisco General, but she will continue to be based here throughout the survey process. In this new role, Terry will provide oversight and guidance to our nursing department and strengthening the overall foundation of our nursing operations. Terry is really critical to our overall recertification effort. She is the perfect person to lead Laguna Honda's nursing operations during this critical period, and we are extremely grateful for Terry's leadership and expertise. Slide. Laguna Honda continues to develop strategies to prevent contraband and illicit substances from entering the campus. Most recently, we implemented a new process for screening visitor belongings and safety searches for patients returning from out on pass. These processes are conducted professionally and courteously by our SFO, SFSO staff, our sheriff staff. We're also working to implement screening technology and narcotics analyzers to assist in detecting illicit substances. Additionally, we've increased security presence in several high visibility areas around the campus, as well as increased clinical searches on various units. Some of those interventions are new to Laguna Honda, but they really are necessary to ensure everyone's overall safety. Slide. We implemented a new tobacco and smoking policy on April 6th. Under this new policy, patients are no longer able to keep tobacco products within their immediate possession. Alternatively, we are securing these products for patients and making them available during designated smoking hours at our Serenity Park, which is the designated smoking area here at Laguna Honda. This new policy is also an important part of our effort to ensure patient safety. We're also implementing an initiative to enhance the environment in our patient rooms. As I mentioned, many of our patients have a practice of hoarding belongings in their room, which can be not only unsightly, but can pose infection risk. So we implemented a new storage system on Monday, the 9th. We're working with patients to identify, label, pack, and pack their excess belongings and make them secure in a storage area here on our campus. And we, of course, will make those items available to patients should they ever be needed. This initiative is really a key part of our recertification effort as well. Next slide. So while we've shifted our organizational focus to recertification, we clearly have to continue our efforts to minimize the spread of COVID-19 in our facility. We're fortunate because we have a high vaccination and booster rate among our staff and residents, and that's really made a significant impact in keeping our case counts to a minimum. Next slide. Our effort to support vaccination among our staff and residents has been very successful, as I mentioned. We are also continuing this effort by making the 4th booster dose available to both patients and staff aged 50 and above. Staff can easily obtain the booster by just simply dropping by our outpatient clinic. And our interdisciplinary team have collaborated and facilitated a provision of the 4th dose for our residents directly on the units. Essentially, this team has facilitated boosters by conducting these visits on the units and completing 2 units per day. And we started this effort on May 5th, and we've essentially completed boosters on all units. There will be a number of individuals who will continue to become eligible for the booster as time goes on, and we will continue to provide those individuals access to boosters whenever they need them. Next slide. So after our termination of our participation agreement, we made the difficult decision to pause our admissions while we're going through the recertification process. This decision is also consistent with the guidance that we've received from CMS as we prepare for recertification. In the meantime, we're collaborating with our network partners to ensure that we facilitate patient flow efforts so that we can assist ZSFG in expanding their bed capacity while we are no longer taking patients. Next slide. So I'm pleased to announce the selection of Brigitte Van Ewijk as our new South 6 nurse manager. Brigitte has over 20 years of nursing experience, including 5 years as charge nurse on our South 2 unit. Brigitte is a recent graduate of the University of San Francisco. She has a master's in the clinical nurse leadership program. She also served as acting nurse manager for the majority of the last year on our South 4 unit. So as you can see, her leadership abilities really have always been evident. This is a very well-deserved promotion for Brigitte, and I'm very confident that she will do an outstanding job in this new capacity. Next slide. And finally, The Affordable Senior Housing Project Plan for eventual construction here at Laguna Honda is continuing to move forward. Meetings related to the project have obviously been placed on hold as we continue our recertification and licensing efforts. Mercy Housing is also conducting a series of meetings with our various neighborhood associations, and we will continue to provide updates to the JCC as new updates become available. But for the moment, we're putting a pause on most of our meetings because really our focus has been on our recertification effort. So I'll stop there and try to answer any questions that commissioners might have.
Commissioners, there is one person on the line, so if you're okay with it, I will move forward and ask if there's any public comment on the executive team report. By the way, thank you, Michael. If you'd like to make comment, please press *3 now. I don't see a hand, commissioners.
Okay, thank you, Mark. At this time, I'd like to see if any of the commissioners have any questions from Michael on the executive team report. I don't see any hands up either. Oh, there, Dr. Chow.
Yes, thank you. I have to find where the hand is. That's fine. I thank you for the executive team report, and I had several questions that arose from it, mostly informational that I was asking, and perhaps I don't know if you want to have them all in one row and then they can answer each one. That maybe that would be the easiest, or we could take one topic at a time. But I had about 4 topics off of the slides. The first was that you mentioned that HAI would be cooperating with CDPH, and I was wondering what type of cooperation we're talking about to become recertified. That is, how does the state of California, which does the surveys, assist us to be able to pass their surveys as we use HAI, and what will HAI's role be in assisting us in not just passing surveys, as you had noted before, but that the recertification process is much beyond that. So what is the scope of HAI's work, and how does CDPH then help us in doing this? Are they here to really then assist us in responding to their concerns?
Thank you for the question, Commissioner Chow. So I will let Nods speak to the HAI piece, but just in general, in terms of CDPH, so CDPH has, and as well as CMS, has made themselves available to us by virtue of regular Teams meetings to talk about various aspects of our preparation and to ensure that we are on the right track. And if additional information may be needed with regard to particular plans that we might be putting into place, they will provide that guidance and redirection to ensure that we remain on track. So that's one piece that has been in place, and that continues. CMS also made available their quality arm, referred to as the QIO, but also known as HSAG, and whereby there are consultants who are actually available and who have been here on site and have now since returned and to be on site to help us with various aspects of rounding, care plan, audits, staff education, reviewing of policies and procedures. So that group is really hand in hand with our organization, helping us to be in the best position possible for moving forward with our recertification. And if you don't mind, Naz, I'll ask you to speak to the HAI piece.
Sure. Good evening, commissioners. So CDPH was able to send support from their HAI team here last Thursday. They were here for a day rounding on a few units with our infection prevention and control staff. The intent of that support was to be essentially extra eyes in relation to the regulations in which CDPH holds us to when they conduct their surveys here. So Item A is the individual who was here, and we are familiar with Item A as she came to assist us in the beginning of COVID. So she's also familiar with the facility as well and our mitigation protocols, as well as our COVID management protocol. So she gave us some great feedback. She will provide us with a formal write-up. We're hoping that we'll get that in the next 1 to 2 days so that we can share that with others. And then, the intent really is to provide us that expertise, right? And while she is rounding with our own IPC staff, so we can correct things to ensure that they also don't come up again with surveyors. HAI is a non-putative arm, if you will, of CDPH. They're a resource to facilities, so folks can call on them to come out and assist them in preparation for survey. I hope that answered your question.
Yes, yes. Well, that part it does.
Mhm.
I was just suddenly remembering that as we're doing all of that, I think Michael had reported that it was also necessary to do a transition plan. So how are these two being done? Because both of them sound like an awful lot of work. And is there a different team that's doing that, or all of you have to sort of pitch in and get both of those done?
Yes, there is a specific team that's working on the transition plan, although, and that work is really centered around our team that are responsible for the patient flow. Irene Blanco leads that team. And so Irene is our point person on that part of the work. But as you might imagine, it involves the participation of a lot of individuals at various levels of the organization. And that plan is ever evolving. And so, but in terms of the actual day-to-day management and development of it is led by Irene Blanco.
Okay, so I'm assuming that as we get progressive reports, that will be an element that you will be bringing into the reports in terms of where we are with that. Although obviously we're hoping never to have to use it.
Absolutely.
Um, so the protocols that you put in, and by the way, I want to thank you for sending forward the CMS findings. And that puts into context, I think, for us better the issues that we're all facing. And so one of the issues that we are facing from that is certainly, the problem, as you've mentioned before, of the culture. And it's quite clear, as they were citing, that we have policies and procedures to follow through with all of that regulatory requirements, but that they weren't being carried out. And you've now talked about, making more, I guess, in-depth review and with a way of using more standardized tool to see that happens. But I'm wondering, because these are human failings, but as you read them, they turn out to be much more than maybe some of us had thought in terms of its prevalence. And so I know that Miss D'Antoni has only been here for several weeks, but perhaps that's an interesting perspective, if she has one, about how she feels in terms of the tools being used and the expectation of success, or are there other, ways in which we need to help support the staff so that they feel much more inclined, even such simple things as we've talked about in the past of hand washing, which is just sort of routine for almost anybody in infection control. It seems that we can't get around getting enough people doing it. So I don't want to put Terry on the spot, but with fresh eyes, I would be interested in what her perspective is in terms of the tasks that she sees ahead of her, and obviously we're looking forward to success on it.
Thank you, Dr. Chow. I've been here, I think, 10 days now. And no, it's a wonderful place. A lot of very caring individuals that work here. From fresh eyes, again, you go into someone else's house, your eyes are open differently and you look at different things. I've come across some things that we need to do. Number one, we have to help the staff come back, get the morale up a little bit, because in order to fix things, the staff have to feel empowered. So we are doing a lot of different things to support the staff. I meet with the nursing directors every morning at 9:45. We go over the plan of corrections. We go over EOC rounds, and we select something of the day. For an example, one of the things are medication administration pre and post when someone has to take a PRN. And so we're only 40% compliant. So today, DET, Department of Education and Training, made labels and we put it on every one of the wows, reminding the staff to do that in a nice bubble form. Another thing we're doing are EOC rounds. We're going to post the EOC rounds on the board so that if a surveyor were to come, the staff member won't have to remember and say, oh, I can't remember that. Come to our board, let me show you. And at the end of the week, we're going to have a contest of who has the best EOC rounds. So we're trying to look at it in a spin where people feel engaged and feel that they're not being put upon, but it's something we need to do. And I'm meeting with a lot of openness, and there are a lot of things we have to look at, but I think taking one thing at a time and building people up is going to be the biggest, and then I'm sure things will move from there. I hope that answers your question.
Yes, it does, and I'm encouraged that you're feeling that the staff is really very dedicated and caring. It's really nice to confirm that, and that it's how we're going to be able to support them and get them to then feel that these are things that really, matter of fact, literally their jobs are on the line for at this point. So hopefully that they will then see the seriousness of the situation. So thank you. Um, my other question is actually related on the patient and family side. Um, I think the protocols that you are putting in place on, trying to uh, reduce the number of contraband that may arise, and uh, the need to be sure that there is lack of clutter in the rooms, and they all sound like solutions that are quite doable. And I'm just wondering, though, how well not just these protocols, but the entire situation is being received by our patients and by their families.
I think generally speaking, two things. One, our patient population is accustomed to change. Clearly, we've come through the last couple of years with COVID, and we've implemented a lot of change over that time period. I think we have really made a great efforts to communicate regularly and transparently with our patient population and our families, and that's helped tremendously in terms of building and maintaining credibility. And so whenever we are faced with having to implement a new change or initiative or process, we try to explain it and the rationale behind it. And it's really, in most instances, driven by ensuring patient safety for everyone. And so I think based on just, you know, having that open line of communication has facilitated making some of these changes when we need to. So yes, there are always outliers who it impacts more and they're more vocal, but those are, you know, are just a few individuals. Generally speaking, even with situations where we've had to restrict patients' tobacco products, one would think that that would be, you know, a major dissatisfier. And with some parts of the population, it was, but you know, we worked through it. We worked through it together, and then they support it. Overall, they support it.
So I'm just thinking back where when we had the situation wasn't here, but was when St. Louis closed the subacute unit. There were quite a bit of concern on the part of patient families. Uh, do we think that the message has gotten out fairly well by either the press and perhaps your internal communications, that families feel more assured that we're doing the best we can and that we are definitely not here, as you've been saying all the time, to have us close, but that we're going to be here? Has that resonated with the families so that there is less anxiety on their part?
I think for the most part, it has. And as I mentioned earlier, I think there will always be a few individuals who will be more impacted or maybe will have more anxiety than others. And some of those will reach out directly, either in the hallways or, you know, via email or phone. Um, and we try to reassure, you know, to the greatest extent possible. But here again, overall, I have to say that I think our patient population and our families are overwhelmingly with us. Um, you know, they obviously don't have access to all the information that we might have, but I think generally speaking, our patients and families are with us and are supporting us in the work that we are doing to become recertified.
Thank you. So I'm really thankful for the summary that you put together. And I think that will be a great reference to see that the areas that you've highlighted are being responded to. And it's really a very nice two-page summary of the citations. And I wanted to thank you for that. So
Thank you. Thank you, Dr. Chow.
those are my only questions at this point on the report.
Okay, thank you for your questions. I'm going to turn now to Commissioner Green.
Yes, well, I would echo that that summary was really very helpful, and I've only gotten partway through the detailed report from uh, CMS, but I think it really is very helpful to have that and better understand the details behind things. Dr. Chow covered many of the things I was going to ask, but I guess I have two relatively simple questions. The first is, as you construct a transition plan, are there any elements that how much of a template is there out there for a transition plan, so you can be assured that you hit all the notes that they expect you to, and that it's comprehensive, even though it hopefully will never need to be activated? And then the other question I have is, can you tell us a little more about the consultants, and in particular, what your expectations are? In other words, are they supposed to stand back and evaluate the situation, give you insights like Terry can with fresh eyes? And what extent do you expect they're going to actually help the development of tools, the development of protocols, and then I assume implementation is all on us, but I'm wondering whether they'll have a supervisory role in that, or what you envision as their, you know, real role. And maybe the different consultants indeed have different degrees of involvement, but I'd really love to understand what your expectations are.
Oh, Michael, if you're speaking, you're muted. There we
Oh,
go.
sorry about that. Sorry about that. I was saying that I'm going to defer to Dr. Hathaway to talk a little bit about the transition plan, and I'll give her a little time to think there. I'll talk about our expectations for the consultants. So consultants arrived today. The organization is HMA. They are very experienced in the healthcare arena. And they will have two functions while they're here. One of them is directly to lead our effort to become recertified, and that application process and all that it entails. But an equally important aspect of their presence here will be around doing an assessment, a top to bottom assessment of our organization, and helping us to um, uh, look at all of our systems administratively and clinically, and to help us to determine where there are areas for improvement. And the team has a tremendous experience in skilled nursing facilities and in healthcare, and the expectation and this is a common expectation that they will be hands-on, working directly with us rather than just being in an office, and making recommendations. And so the work is just starting now, but it will ramp up very quickly. We will integrate them into the incident command center meetings, to give them, and we've already provided them with a tremendous amount of information about the organization as well. And so, yes, we are expecting, and they are fully capable of really looking at our organization from the top to the bottom and helping us to identify areas where we can do things better, and where we can improve our systems.
And Commissioner Green, I'm going to stop the discussion of the transition plan because that was something that was mentioned in closed session at your full commission meeting. And it's a very important topic, but because we're in open session and we haven't gotten permission from legal to where and how to discuss it, let's hold off on that, even though your question is a very important one, and we'll figure out a way to get an answer to you. But in terms of discussing in open session, let's pause that topic. And if you have other issues or questions, please feel free to move forward with them.
Yes. So implementation will all be, they'll evaluate, but then when it comes to developing tools and implementing them, that'll be all within the organization. Is that right? Is there an RFP for the organization that you could share with us? Just to have a better idea of some of the details of the expectations, as you put this out. I know you develop it very quickly, but is there one?
Yes, there is. I will coordinate with my boss, Roland Pickens, and Greg Wagner, the COO for DPH, to get that, because I wasn't directly involved in that piece, but it does exist, and we'll be happy to provide it.
Great, thank you. Those are the only questions I had.
Thank you, Dr. Green. And I see Roland, your hand is up. Did you have?
Yes, can you hear me?
Yes.
Okay. So, Mark, I won't mention the transition plan, but is it okay for me to talk about the consultants?
Sure, absolutely, yes.
Okay, so yes, I can provide a little more color as relates to the consultants. So, and actually that's where Michael and I were, well, that's why we were a few minutes late joining you. We were meeting with the Health Management Associates consultants, along with Director Colfax and Greg Wagner. So as Michael shared, we have actually two different consulting groups. One is HMA, who we met with. They just arrived at Laguna about an hour ago. And Michael will get that scope of work to you. But basically, they responded to an RFP for two distinct, what we're calling tasks. The first task is to help Laguna prepare for and be ready for CMS recertification. And as directed by Dr. Colfax, that is their number one priority. The second task is the top to bottom assessment of Laguna Honda in terms of its administrative, its clinical operations, its quality, its patient safety, its infection control and prevention, the entire organization, and the organizational culture. Um, Michael serves as the lead for task one in terms of the recertification process. I am the lead for the top to bottom assessment. Um, while those two are separate, obviously there is a, convergence for some of those activities. But as directed by Dr. Colfax, we've asked them to first focus on recertification, and then on the heels of that begin the task two, which is the top to bottom assessment. That's HMA. There's another consultant, which Michael mentioned, the HSAG, Health Services Advisory Group. Just to give you the history, CMS contracts with different specialists around the country who do only one thing. They specialize in CMS regulations. And that's what this HSAG group is. They were here the week before April 14th to help Laguna to really focus on those illicit substance issues, which everyone thought was going to be the focus and was the focus when the state came in. So they didn't really do a lot of work in terms of overall hospital environment of care, but they're now back because these are the experts that actually work for CMS, and CMS makes them available to hospitals around the country to help those hospitals make sure they're meeting all CMS regulations. They are here. They arrived yesterday with a team of 4. They will be here every week for the next several months, Monday through Friday. They'll fly out on the weekend and come back Monday through Friday. And we are expecting that same cadence with HMA. Again, these are on the ground consultants who will be initially doing assessments, but very much, and we saw this with HSAC QIO when they were here before. One of the metrics was they ended up interacting with 86% of all of the frontline care workers at Laguna last time. They met with nurses, CNAs, porters, everyone. And so these are hands-on people who will be assessing, helping to create new tools, working with the leadership, and making recommendations, both in terms of CMS regulation compliance, but also overall process improvement. So I hope that answers your question.
Thank you. That is so helpful. I really appreciate that detail, and it sounds like they're really hitting all the marks we need to address. So thank you so much for that detail.
Okay, and I don't have any additional questions. Commissioners Chow and Green addressed most of the inquiries that I had, and Roland, thank you for the detail on the consultants. I did have a request, though. I was wondering, since there are so many different timelines and deadlines, I'm wondering, is there a way that you could sort of graphically represent all of those on a, on some sort of visual, as opposed to just their sequential dot points on just so that it'll be easier for us to track as we go along, following everything that's going on, and that would be really helpful, I think, for not just the Joint Conference Committee, but also for the full commission to have.
Absolutely. We will take that back as a to-do for the incident command structure. And so we're using incident command to really be that layer above regular Laguna Honda operations. This is the DPH incident command that Director Colfax chartered. And so I am the executive sponsor of that Laguna Honda incident command. And you'll remember Troy Williams and Baljit Sangha are the co-incident commanders. And so Michael plays a role. He is the operations section chief within incident command. So we will, as part of incident command, put together that timeline so you can see how all of these consultants work together. Is that the request?
Yes, yes. Yeah, and then the timeline, yeah, on the deliverables, or at least key milestones,
Okay.
milestone dates. Okay, great. And again, adding my thanks and support to the team there for everything that you're doing, and to the rest of the staff and the families that are working with you and trying to, you know, adjust as needed, all for the good, certainly of Laguna Honda and our residents, but you know, as much as we can sort of keep in mind that this is all for the good and for the better, the disruptions, you know, considering our resident population, can't be easy to either, you know, have to be the folks on the ground making those adjustments on behalf of the residents and, you know, on staff, as well as those who are feeling them and having to do that. So want to, again, just be as sensitive as you possibly can to everything that's going on there and what you have to do in order to make sure that all of these changes are both well received, followed, and as I think with as much compassion as we possibly can provide in implementing them. Okay, Mark, I think we can move on.
Yes, if I may make a piggyback on Mr. Pickens' comments, HMA was the consultant that the DPH used to reorganize itself in 2011 and 12. So just to give more context, it has a long history with the DPH, and therefore it has some history with Laguna Honda, because way back then it helped divide us into PhD and the network, just as a FYI. Item 5 is the regulatory affairs report.
Thank you, Mark. And thank you, Zoe, for pulling it up. Good evening again, commissioners. So this is our regulatory affairs report, and just for level setting, it is just our high level overview. Of course, I'll be happy to answer questions, as this is part of our QAPI and monitoring plan that we ensure we bring all these items forward to you on a regular cadence. So since we were not able to come together in March, this report covers 2 months worth. So for March and April, the facility had a total of 40 facility reported incidences to CDPH. We also received 2 anonymous complaints from CDPH. And again, just as a friendly reminder, anonymous complaints are directly pointed to CDPH, and then they let us know as the facility if they receive them. Otherwise, we are not aware. And of course, the breakdown of those facility reported incidences are below 25 of which were in March and 16 in April. And again, the highest subcategory being allegations of abuse, with that being resident-to-resident altercations. And as we go down, we'll see our survey activity, which you all are aware, since we were in constant communication regarding the activity we were having in March and April. We did have one unrelated site visit March 8th that was for 2 surveyors following up on facility reported incidences and 1 anonymous complaint. And then the rest of the survey activity is related to the 2nd and 3rd revisit from the extended survey in October. As we go down, there were a number of plan of corrections submitted in March and April, most of them related to the 2nd and 3rd revisit, which the facility had supported in March and April as well. And then, of course, you have the rest of the data in front of you. Are there any questions or comments? I do want to acknowledge a question that was shared. I know we responded via email, but just to share here. As you know, this is a great one to stop on. Thank you, Zoe. So you'll see there are still a number of investigations that have not been started with the facility. And so we've been partnering with CDPH to get understanding of, will these cases be closed? Will they come on site? What are we to expect? And so they have shared that they still will come on site to close out all these cases. The quality management team has prepared to ensure that we have all our case files and materials ready for whenever they come on site so that we can be as responsive and supportive of them to turn these around quickly, with the same common goal to ensure that Laguna starts with a clean slate, if you will, as we re-enter the participation with CMS program. So the timeline is uncertain, but we are ready in the QM department to support them whenever that might be. And happy to answer any questions.
Okay, let me first, Mark, is there anybody on the line?
Thank you, Commissioner. Folks on the line, if you'd like to make comment on item 5, the regulatory affairs report, please press *3. I see a few people, so let's give them a 30 seconds. Again, *3 to raise your hand so we can recognize you. All right, I do not see any hands, commissioners.
Okay, then I will go to Commissioner Green for a comment or question.
Yeah, and you may not be able to answer this, but I'm just curious. So I realized from, and thank you for your extensive responses to the questions that we submitted. I realized that you've all fairly carefully vetted all of these FRIs that are pending with CDPH. Do you have any sense of whether our internal evaluation of these complaints matches well with how the conclusions CDPH raises? I realize it's been years and they're delayed because of COVID, but are we fairly confident based on our history that if we've really thoroughly evaluated these, that there are not going to be any surprises in one direction or the other from CDPH?
That's a great question. I don't have the percent breakdown, which we probably could look at, but I would say on average, our outcome that we have internally, so for instance, whether we substantiate or unsubstantiate a case, generally matches what then CDPH will also put forward. And to that end, what can often happen when someone comes to investigate, they might look at other things. And so we will, for the most part, be aware of what those potential gaps or areas of concern may be. And so we'll try to work with staff to do some kind of just-in-time corrections so that we can show CDPH when they come on site that the facility attempted to correct the incident. So a more tangible example would be documentation, right? So as my team is doing their review and printing documentations, they often follow up with our clinical colleagues and say, oh goodness, can the physician please go and make a documentation, or nursing didn't do their note, we need this note in there to ensure that, to your point, everything is how it needs to be. And sometimes, right, with respect to late entries, it's a late entry. And so it will be dependent on whether the surveyor will accept that late entry or not. But we do our best to assess, and more than not, we match up with their outcome. If for whatever reason, let's say we unsubstantiated something and they end up substantiating it, we take that very seriously. And we do go back and confer with generally nursing leadership to discuss, why did we not substantiate it? Do we want to reconsider? Should we open the investigation again? So we do have those discussions because we want, in theory, especially in quality, we should be in line with what the regulators come and review as well.
Thank you. That's really helpful.
Okay, Dr. Chow.
Yes, thank you. I have a simple question. We've submitted the plans of corrections from March, through April the 8th. Have these been accepted?
Yes, all plans of corrections that were submitted have been accepted.
Okay. No, thank you. It might be helpful just to note that they were accepted so that we won't have to ask you.
No problem. Happy to do that.
Okay, thank you, Commissioner Chow. No further questions, and we can move on, Mark.
Thank you again, Naz. Item 6 is the pharmacy update. Dr. Powell.
Hi, sorry, I just had someone knock on my door. What perfect timing. So good afternoon, commissioners and Laguna Honda Network leadership. On an annual basis, we usually talk about the medication error reduction plan here at Laguna Honda, and so that is what I am speaking about today. Next slide, please. As many of us recall, in 1999, the report to Errors Human detailed the prevalence of medical errors, and it really was the impetus for the patient safety movement. So as a result of that, in 2001, all acute care hospitals were required in California to develop and put forward a medication error reduction plan, which we refer to as our MERC. And that is, to promote ongoing review of creating a safe and effective medication use in the healthcare facility. And back in 2001, it was pretty novel to talk about the implementation and use of technology being required. And we were challenged by that in the early 2000s, but we've come a long way since then. Next slide, please. So there are 11 procedures and systems that essentially go into the medication process: prescribing, prescription order communication, how we label the products, packaging and nomenclature, compounding, dispensing, distribution, administration, education, monitoring, and drug use. And so our plan is required to hit all of these elements. The purpose of today's presentation is really to highlight changes that have occurred. I believe in a previous JCC, you may have had the full MERP plan that you reviewed. And so I'm just going to go over highlights today. Next slide, please. So prescribing and prescription order communication. With the implementation of Epic, we have a lot of tools for the entire MERP plan, the entire medication use process. Order sets and order panels are one of those. One of the things that we've looked at here at Laguna Honda is a breakthrough seizure order set. This really has to do with our number one reason for calling a code at Laguna Honda is someone who is seizing. And typically the medications that we use to interrupt those seizures are benzodiazepines, which are controlled substances. And often folks struggle with getting those medications out of the Omnicell cabinet, partially because of the stress and anxiety of the emergency. And also partially because they may not have a standing order for those items. And so the goal with the breakthrough seizure order set is that patients with a seizure history would have a standing order on their, I want to be careful about using the standing word because that refers to things that don't require a actual order from a physician. So I'm going to back that up and say that they would have an order in place for those medications, and therefore no overrides are required. The nurse can pull up the patient in the cabinet and go directly to that product. That order set has been developed. We are very close. We worked on it last year. It's pretty much ready to go, and so will be rolled out here at Laguna Honda shortly. We also had a number of COVID therapy order panels that were implemented in this past year as treatment became available for COVID. And so that's another example of new panels. We continue to participate in a network-wide group that is working on optimizing clinical decision support. And so there are nurses and pharmacists and physicians from Laguna Honda that participate in that clinical decision support group. for DPH. Next slide, please. Product labeling, something that we did a couple of years ago when we had survey issues around expiration dating on prescription labels. With the change to Epic, our labeling changed dramatically. And so those continue to auto-populate on the prescription label if they are an item that we would expire sooner than the manufacturer's expiration date. That does require some ongoing monitoring. If there are changes in Epic, we have found that that will drop off. And so we monitor that on a regular basis and add to. We also had a couple of unusual errors in the last year where an ODIC, or a product for use in the ear, was inappropriately given as an eye drop. And so we looked for and purchased and implemented the use of a ODIC auxiliary label. So those are two examples of labeling changes and updates in the recent past. Next slide, please. Packaging and nomenclature. We are planning, so we already use an automated packager at Laguna Honda. We've had these automated packagers in place since we moved into the current hospital building. And it essentially spits out the medications in a little packet, a little pouch that is labeled. And it really is key to our ability to provide a 24 or 48-hour supply of medications and not fill a longer supply. So it helps us limit the amount of medications that are available on the nursing unit, which is important. Our packagers are now at end of life, and so they require a lot of care. We are in the process of upgrading our automated packager, and it's been delayed. I would have liked to have told you that it had been put in place in 2021, but of course, the machine that we're replacing it with, even though it's essentially the same machine, has changed by about 1/4 of an inch. And therefore, its footprint has changed, and therefore we need new seismic restraints, which has caused us to have delays. But with that comes, with that new packager, we are also purchasing and will implement the pouch inspector, which allows a computer to essentially check the output of the packager. And I've included on the slide a picture of our #1 error that comes out of the pharmacy right now, which is when the packager drops 2 tablets into the pouch instead of just 1. And this is something that the pouch inspector, right now we count on pharmacists and technicians as they are checking thousands of these pouches every day to catch that rare pouch that has 2 tablets. And to err is human, especially with tasks like that. So this Parata Pearl pouch inspector will actually, I look forward to it in adding efficiency and also in mistake proofing our processes. Next slide, please. Another area is compounding. Compounding refers not only to creating an oral solution, either from crushing tablets and mixing things, or but also our sterile compounding, which is key. I certainly remember in the early to mid 90s when there were a number of incidents that occurred with compounding errors, and especially with contamination of sterile compounded products that led to deaths, some right here in Northern California. And since then, there's been increased emphasis on the sterile compounding process that we have in pharmacies throughout the United States. The regulations continue to become more strict. And with that, we are in the midst of a capital project for a clean room upgrade. It's currently sitting with what used to be OSHPD for approval. And it will provide, currently we have these containment isolators. So they're like the glove boxes where the person stands there, they put their hands through these gauntlets and work inside this little cupboard kind of space. And that is okay, but it's not ideal. And we also have to maintain a clean environment outside of that area, which we find challenging as we're getting stuff through our HVAC system that occasionally will grow bacteria on sampling. So this new, this capital project will provide a dedicated HVAC just for the sterile compounding area, as well as some additional changes in the rooms so that they will be, in fact, true clean rooms. So I don't have a timeline on that, but it is underway and we're excited about that. Next slide, please. Another item when we moved to the new hospital is we were able to utilize these automated dispensing cabinets. We happen to use Omnicell within PPH. These automated dispensing cabinets are in use both at Laguna Honda and CSFG. We're in the process of upgrading ours. Ours are currently at end of life. And we're also expanding to the jail health service. We're currently in contract negotiations. We've recently had progress in our DPW portion, which is again for seismic bracing because the bracing requirements have increased since we originally moved into the current building. These cabinets are critical to an acute care hospital dispensing model where approximately 98% of doses are dispensed through the automated dispensing cabinets. And in skilled nursing, the skilled nursing side, the patient nursing ratio doesn't really support using the cabinet in the same way, but it is critical to our control of controlled substances. So our controlled substance oversight is key. Next slide, please. Distribution, no major changes there. We are continuing to limit medication on the units, as I mentioned before, to 24 and 48-hour supply. So that's for items that are not in the dispensing cabinets. Next slide, please. Administration, in the last year, we upgraded our smart pumps. And we are on the same version of smart pump as most of ZSFG. Pumps are rather complicated, and at Laguna Honda, because we have a limited number of IV medications that we give, we're able to really have just one pump. At ZSFG, they have multiple pumps because you can't use the same type of pump for example, for a patient-controlled analgesia or for epidurals require a different kind of pump. So we're fortunate at Laguna Honda, we get to limit ourselves to one. Other items under administration, nursing has done a tremendous amount of work and at increasing spot observations of medication administration. And we've standardized the tool that we use for medication observations and also put it in a single data repository. We used to, pharmacy would report out theirs, nursing was doing some as part of the performance appraisal process, but that data was really siloed. And so we have combined it into a single data repository, which makes the data much more valuable. And so that's been incredibly helpful, and there's been a lot of work, but it is well underway and utilized in the past year. We also replaced our end-of-life medication carts. So it's, you know, the life cycle on all of these things. We've hit about 12 years that we've been in the current hospital, and all of these, our packager, our Omnicell cabinets, and our milk carts, all are feeling the that time, and all coming due for replacement at about the same time. Next slide, please. Last year, we really talked a lot about the barcode med administration and the tremendous amount, again, huge kudos to my nursing colleagues. One of the things that I was most excited about in our transition to Epic was the ability to do barcode med administration. It is probably the most powerful medication safety tool that we have. And it was a challenge in the beginning as we moved to Epic. There were many changes, but additionally, it was so different from our previous workflow. And nursing leadership really embraced BCMA and began to work with their staff. And over time, we have reached our goals of being at greater than 95% compliance for the combined scanning of the patient as well as the medication, because that's where you get your biggest bang for your buck. We have had dips in both January of 2021. We didn't quite make 95%. This year in January, we did make 95%. Both of those months were huge surges, big surges in our COVID cases. And we had a lot of people in isolation. And when they're in isolation, you actually are not doing the scanning of the risk scan. Next slide, please. Monitoring. So as you're well aware, we had challenges with some medication orders that were automatically expiring. In Epic, we did revise the standard work for monitoring the expired medication orders, put in a much more robust process around that. Also, medicine really embraced their role in monitoring and watching for those clues on their work list about expiring orders. And so we've come a long way in that process over the last several months. We've also improved our investigation process for unreconciled pulls of controlled substances. Again, it is a place where the collaboration or the interface between Epic and our automated dispensing cabinets is key in that it provides us with critical information to really provide a robust controlled substance oversight program. Next slide, please. Drug use, we do a number of things that we monitor and do some annual quality monitoring, some ongoing quality monitoring. Annual antipsychotic use, we look at antipsychotics because they are so heavily regulated in skilled nursing facilities. And so looking at that data, really we're looking at it on an individual case basis on a monthly basis, but really looking and collecting the data and looking at trends on an approximately an annual basis is helpful to us to have our documentation in place, identify challenges around documentation with these medications. We also look at fentanyl because of its high risk. nature. And so making sure that we have our documentation in place and that we're doing the adequate screening and to assure that all fentanyl prescriptions are appropriate and that people have adequate opioid tolerance before being prescribed a fentanyl patch. And then antimicrobial stewardship, so important for healthcare as a whole and for being able to maintain the usefulness of the antibiotics that we have available. So we have a robust antimicrobial stewardship program. Here at Laguna Honda, it's a model, I think, for skilled nursing facilities, although there are none quite like Laguna Honda. And it would be difficult to replicate in community settings, but I think we do an outstanding job there. Next slide, please. So current plan of correction work. While the surveyors were here looking at our expired med plan of correction and the processes that we put in place. We did great. Medicine, pharmacy, nursing, all were able to speak to that. We did uncover during that process, they identified 2 medications that had not been given because the med was not available. I want to put this a little bit in perspective. We administer about 10,000 doses of medications at Laguna Honda every day. And so 2 is not a lot, but it does uncover kind of a gap in how we're addressing those. And so we are currently looking at medications that are listed as not given because medication is not available. We developed standard work, collaboration between pharmacy and nursing that really addresses where to look for medications, how do you know where it should be, escalation, critical thinking, and documentation. We're also, and we are collecting data now on a daily basis and providing feedback to nursing. Additionally, I'm looking at this data and looking for, how do we optimize the pharmacy dispensing workflow? How do we improve having the med there when the nurse needs it? We have found by looking at this data, there are some opportunities for improving and anticipating when the medication is going to be needed so that we're delivering it the day before instead of waiting for nursing to ask. And also utilizing our Omnicell cabinets. Are there places where we can add a medication to the Omnicell to alleviate the med not being available? Another area that came up was bedside storage of treatments and herbal supplements. So again, collaboration between nursing, medicine, and pharmacy, adding clarity to policies, going back and looking at some work that was done just prior to the pandemic that kind of got sidetracked and looking at providing a one-stop shop for the PCAs that they need so that the equipment and supplies that they need are available in a single and convenient location. And then also really examining the herbal supplements that some of our patients are using their own personal herbal supplements and making sure that we have adequate locked bedside storage for those products. So those are things that we're working on right now that are related to medication safety. Next slide, please. Just a reminder of the medication-related committees. There's actually a lot of them here at Laguna Honda, Pharmacy and Therapeutics, our Med Error Reduction Subcommittee, Drug Diversion Task Force, which we mostly refer to as Controlled Substance Oversight, Psychotropic drug use subcommittee, again, important because of the emphasis, regulatory emphasis in that area. Pain, diabetes task force, falls committee, code blue committee, med nursing, combined QI, nutrition subcommittee, product evaluation, performance improvement, patient safety, infection control. And then the last two are areas that are related to our electronic health record and clinical decision support and pharmacy domain. Next slide, please. A reminder of the resources that we utilize for improvement. We use a variety of external resources that are listed here where we're looking for best practices, as well as internal resources, the reports and data that we review on a at least a monthly basis and sometimes more often to guide us in where the challenges are. Next slide, please. And the future endeavors, upgraded automated packagers, we talked about that. Earlier, electronic checking of packager output, the new equipment that we're looking forward to. The automated dispensing cabinet replacement, that's our OmniCells. Workflow optimization, all of our technology, it will not work on its own. We have to have workflow that people are able to embrace. And then an ongoing looking at expansion of oral liquid unit of use. We added a couple of items in the last year and hoping to add another couple of items to do unit of use, as well as putting those out in smaller quantity to the units. And our overall goal is really to have a very safe medication system here at Laguna Honda. That I will take questions.
Okay, thank you very much, Michelle. Let me see if there are any public comments or questions.
Thank you, Commissioners. Folks on the line, if you'd like to make comment on item 6, the pharmacy update, please press *3 now so we can recognize you. Again, *3. I don't see any hands, Commissioners.
Thank you, Mark. I see a hand by Dr. Green.
Well, first of all, thank you for the presentation. I really want to congratulate you on the progress that's been made, especially with barcoding and the work you've done to make sure that if a doctor is on vacation, the meds don't fall off and so forth. So I think it's really laudable what you've done. One of the things that did strike me as I started to read the CMS report was this question of herbal medications. And I don't know if the one example they gave is representative of other residents, but I wonder if you have a sense for the percentage of residents that in fact do have these various supplements at their bedside or that they prefer to take them. And knowing there are, I think, 29,000 of them, and there are multiple interactions with medications with some of them. I wondered whether there are any best practices or how we approach that conundrum, whether there should be a limitation on these. I know when I look at Epic myself with some of my patients and they've got things that are listed, you really don't know the doses. It's really difficult to understand anything about how much active ingredient, much less the fact that these substances, thanks to DSHEA, are completely unregulated. So I wondered if you have any thoughts about that and whether, I guess it's this balance between resident autonomy and some of the complications you can run into, as well as the amount of work involved in keeping track of these things. I wondered if you had thoughts about that.
Yeah, thanks for asking that question. I agree it is extremely challenging, the labeling on these products, and because they're unregulated, you can't even guarantee that what's on the label is what is in the product. What we have committed to doing and are doing at this point and have for about the last year is one, to have the provider write an order. It's a nursing communication order that is and also for provider and nursing to collaborate with pharmacy. And then we will do a check against the databases that are available. There's a couple of databases that are available, and then if you can't find any in the FDA or national websites, then I go to meds.com, which often has information on some of the supplements. And we do a comparison of what the product is and search for drug interactions with the what is supposed to be active ingredient along with their Western medicines. And oftentimes, or not oftentimes, but that's really what we're looking for is what's the risk. And so when we're doing that assessment, we're also looking at, how narrow of a therapeutic range do their Western medicines have? An example, if someone's on warfarin, I'm a lot more concerned about them taking supplements than if someone's, taking an aspirin a day, for example. And so weighing that risk and benefit, and then just having that information available. So based on, here's the list, here are the drug supplement interactions that we're aware of, and hopefully help the physician weigh that risk and benefit to influence the ongoing conversations with those residents about the products that they're taking. I will say that the one that is listed in the by CMS is a bit of an outlier around quantity of products, number of individual products and quantity of those products. And we only have, not even 10 residents that are using their own herbal supplements. We also, there's a few supplements that we provide on our formulary. So there, I'm trying to, one example is we do provide a cranberry product as an alternative. If someone is having frequent UTIs, there is some data that cranberry juice or these cranberry products will acidify the urine in a way and help deter recurrent urinary tract infections. And so we provide that here at Laguna Honda. So yeah, it is very challenging, and yet people have self-determination. So it is balancing those.
Well, thank you. And I'm glad to hear it's a very small number of residents, because it must be painful for the physicians to even try to find how to enter this in Epic, because if you don't have the perfect dose, et cetera, sometimes Epic simply rejects it. And it takes a lot of work to figure out how to jigger around in Epic to get some of these things even on the list. So I'm delighted to hear that this doesn't represent a large number of individuals.
Okay, thank you very much. Oh, I see Commissioner Chow now has some questions.
No, thank you. And I would actually echo Dr. Green's point about the a barcode administration, which really seems quite remarkable that you've been able to achieve such a high level within a short period of time. Understanding from the past the difficulties people were having with it. So really it's good. Also, thank you for the plan of correction updates. I was curious though, as some of the corrective actions would require, as you pointed out, either new or updated equipment and all. How, as I was reading the state's critique, how do we really get around right now on those people in which a drug doesn't show up? I know there was a description, but it seemed rather complicated or else convoluted, or matter of fact, somewhat disjointed. So if I have a patient who is supposed to get their 4 p.m. Coumadin, but it didn't arrive, maybe a Coumadin's a bad choice because that probably comes up automatically. But whatever it is that was supposed to be given at 4 p.m., but it isn't there. It sounded a little confused as to how I get it. First, of course, as a uh, administration person, whether it be the nurse or LVN, that person has to know how to request it. And do you have then the ability to get it to them, as it seemed to indicate in some of the documentation from CMS?
Yeah, so Epic really facilitates some of that communication. The nurse can make a request directly from the MAR. So as they're working off their med administration record, if they find that they don't have the medication, they can send a message directly to the pharmacy. But that's only, that's the first step. So pharmacy fills it, and we monitor that inbox for requested doses. So we fill it again. The transparency in Epic, I'm able to see actually when they started to fill it, when the pharmacist verified or checked that dose to go out. But we have, I wish we had more frequent delivery, or I also wish we had a tube system and we could just pop it in the tube and send it to the nursing unit right away. So we make several deliveries throughout the day. Nurses also have the option of, sending the unit clerk or a home health aide down to the pharmacy window to pick it up. And that is, really where the gap happens, is the request. Making the request to the pharmacy is the easy part. And then it is the follow-up and the critical thinking of, okay, so if I don't have it yet, there are some meds, if you have a dose due at 9 and another dose due at 1 o'clock, a 2-hour delay, now you're halfway between both doses. Do you want to give the missed dose when you get it? And then another dose 2 hours later? That might be too close together. Luckily, most of our meds are once a day, so giving it a couple hours late is probably just fine. But it is that step, the critical thinking, the escalation, and then the documentation. I went ahead and give it. That documentation is easy. If I'm not going to give it, documenting what your thinking process is, your assessment, and your recommendation of, okay, we're not going to give it, we are going to give it. And that was what, I think that's what caused the concern, was the lack of documentation. So that is really part of our standard work. Our standard work really walks people through, here's, you don't see it, what steps do you take? And then after you make that request, what additional steps do you need to take to make sure that we're getting the meds to the patient? And again, so important for me as a pharmacist to look at that data and say, okay, how can we do better in the pharmacy to have fewer missed meds, fewer meds that they can't find? So how do we anticipate? How do we improve our delivery process? So we're looking and trying to come at this from multiple sides.
Thank you.
Yeah.
Michelle, again. Oh, I'm sorry. Oh, Dr. Chow, you had more questions?
No, I also had just wanted to thank her for the clarity of the problem and the very thoughtful dissection of it. And I think to end up that critical thinking is really the issue we can, and that would seem to be part of the culture that has to actually happen. So I really appreciate the evaluation and the analysis. Thanks.
Yeah,
And-
I think I just want to emphasize that all of this is, it's the medication process is not the pharmacy. It is, I could do everything perfect in the pharmacy and we can have an awful system. Nursing medicine could be perfect and pharmacy is not. And so it's just so important that we all collaborate together and that we come up with the solutions together too.
Okay, and I appreciate that last comment that you made, Michelle, because it really does speak to the culture at Laguna Honda needing to really sort of continue to be folks seeing themselves as one part of a whole in coming together for solutions and the critical thinking that's necessary. And also want to lend my thanks uh, uh, to you for that comprehensive report. I know that the issues of, the drugs and pharmacy and all the controls and all of the system, and the issues that have come around over the past several years, it's been a focus of the committee, the conference committee for a while, and so really appreciate the detail that you went into, on this report and continue to I look forward to more improvements and more critical thinking and solutions implementation as we go forward. Okay, I think, Mark, is that the end of the agenda for the open agenda?
Yes, there's a consideration for a closed session, so we need a motion, then I open up for public comment, and then we can do that, but those things have to happen.
Move to
Okay.
go into closed session.
Is there a second?
Second?
And before we do so, I will ask the person on public comment line, if you'd like to make comment on item 7, the closed session. Please press *3 to do so now. Again, *3. All right, so what will happen, person on the line, is that the group will go into closed session. The meeting will return to open session, so you're welcome to stay, but know while we're in closed session, you will not be able to hear or see us. So commissioners, I'll do a roll call vote. Commissioner Guillermo,
Yes.
Commissioner Chow,
Yes.
and Commissioner Green.
Yes.
Great, please give me 30 seconds to switch us over. We are back in open session, Commissioner, well, everyone. And note that you probably all have been muted because that's what happens. And you are at a point where you could consider a vote to disclose or not disclose discussions held in closed session.
Okay, may I have that motion?
Move not to disclose.
I would second.
I'll do a roll call vote. Commissioner Green,
Yes.
Commissioner Chow,
Yes.
and Commissioner Guillermo.
Yes.
All right, thank you. You voted to not disclose discussions held in closed session. And now, commissioners and everyone else, unless you have other comments or questions, it is time for a motion to adjourn.
Okay, can I have that motion?
So moved.
Second?
Okay.
I'll do a roll call vote. Commissioner Green,
Yes.
Commissioner Chow,
Yes.
and Commissioner Guillermo. All
Yes.
right, thank you all.
Okay, thank you all. See you next time.